We are down to the last speaker, which means we'll have a few minutes for few more questions. Happy to introduce Vinoth Kumar, again, another colleague of mine. He's an upcoming researcher, so he's been working in LAICO, and he's sort of involved in the full life cycle of any research project, from writing up the proposal, getting the ethics approval and grant writing, data analysis, and also drafting the publications. He's also amongst the few certified RAP trainers, recently got certified, and he's got a growing interest in community ophthalmology and operations research. Vinoth.
Thank you, sir, for the introduction. So good afternoon, everyone. So I'm here to present our work on impact of tech-enabled vision centers in achieving 2030 global eye health targets. So hoping everyone is well aware of vision centers. Today, I won't be focusing on the structure or operations of the vision center. Instead, I'll be sharing insights on how technology embedded within the VC model impacted the community. In terms of population coverage, how it has resulted in robust demand generation, and how it provided meaningful community level impact data. Aravind has been using vision centers since 2004, integrating digital technologies, and these include using electronic medical records, teleconsultation with the ophthalmologist based at the base hospital, then AI-based fundus imaging for DR screening, then using digital solutions for administration purposes, finance, operations, then linking the supply chain system for everything. So this technology integration has resulted in a robust demand generation and population coverage. So on average, each VC, for vision center, I will be using the word VC. On average, each VC serves around 10,700 populations with a daily average OP of 34 patients. So the estimated population coverage is about 35%. So for the year 2024-2025, our 7 vision centers from the study area collectively served around 74,800 patients and advised cataract surgery for 3,600 patients, and spectacle advice was given for around 8,600 patients. And this is largely attributable to the deployment of digital technologies. Though the VC has been operating for more than 2 decades, there is little evidence around the impact on the prevalence, eye care utilization, or coverage. So this led us to ask the research question: what is the community level impact data of using digital technology enabled vision centers? So to answer this, we conducted a population-based cross-sectional study in Theni district, which is a southernmost part of the India, using so we recruited 7,127 individuals aged 40 years and above, using a cluster random sampling with probability proportional to size. We then classified those clusters into 2 groups. One is VC villages and the other is the non-VC villages. The VC villages consisted of residents living within a 5-kilometer radius of VC, and the non-VC villages included residents from beyond 5 kilometers. So moving on to the results, the total VC villages had about 15 clusters, while the non-VC villages had 19 clusters, and the total number of population is around 3,100 from the VC villages, and the non-VC villages had around 4,000. So demographically, both groups were comparable in terms of age and sex distribution. And this provides a strong validation for comparing those two groups. And this is where the impact is striking. You can see that the light blue represents the VC villages and the dark blue represents the non-VC villages. You can see that the age sex adjusted prevalence of visual impairment is 39% lower in the VC villages. And the same pattern is you can see for the mild and moderate vision impairment as well. And regarding the eye care utilization, so again, the dark blue represents the VC villages, the light blue represents the non-VC villages. You can see that the overall utilization is 28% higher in the VC villages compared to the non-VC villages. And this trend is consistent across different subgroup of people, including people with visual impairment, cataract, and other specialty eye conditions. Regarding the coverage, you can see that the light blue represents the VC villages, the dark blue represents the non-VC villages. The coverage for cataract services is much better in VC villages with 28% higher CSC and 37% higher effective cataract surgical coverage and 10% better surgical outcomes. And regarding the refractive error services, the impact is even more greater. You can see that the VC villages had 87% higher refractive error coverage, 96% higher effective refractive error coverage, and 4% better vision correction. So among those needing near vision correction, you can see that 77% higher coverage was seen in the VC villages. So to summarize, the residents from the VC villages experienced a better prevalence. I mean, the VC villages had a 39% lower prevalence and 28% higher eye care utilization and significant better coverage for cataract and effective refractive error coverage. And this clearly demonstrates that the technology embedded vision center model has the potential for making a true impact at the community level. So regarding the learnings and lessons, as everybody knows, the field survey is always challenging, particularly related to this study. It was very much challenging to getting the expected response rate. And because of this, we had to do a mop-up activity, and which took additional 3 months. And the other challenge is publication and dissemination of the research findings. Especially this is even more challenging for researchers who are from developing countries. And the third thing is, I have been in eye care research for about eye care field for about 11 years. Basically, I have completed my master's in social work. So I have learned research by doing only. Suppose if I had a formal education like epidemiology or public health, I would have benefited more. Thank you.
One question specific to Vinoth, and then we can open up for other speakers.
Yeah, yes, ma'am.
No, it's a fantastic research actually. It's learning experience for us that you can correlate the prevalence in vision center and non-vision center area.
Yeah.
But could you see the difference in various vision center also? Like in one vision center, some better prevalence or something, in other it is not there. There may be other factors also.
We didn't do that subgroup analysis, but overall it is
Same thing.
same. Yeah. Thank you.
I have another 10 minutes before coffee break, so any questions are welcome. Maybe I would like to start with, okay, so please go ahead. I think you have to have the preference.
My name's Andrew. I'm from St Andrews University. Asano.
Sanim.
Oh yeah. So I was wondering, I didn't quite get the flow diagram of your thing. It was a brilliant idea taking the screening to high pathology endocrine clinics. And if you don't have a diabetes register, then that's what you need to do. And that's what low and middle income countries do. And it's good that Australia's doing that. But I didn't quite understand. Of 100 people that sat down at your machine to get an image, how many end up with an image? Of 100 people that sat down at your machine, how many ended up with an image that you could read?
Gradable.
Yeah, we compared to other studies, I mean, for some reason we could get more than 85%. So it was 12.7 was the ungradable images. And
But 1 in 4 couldn't image themselves.
yeah, that is we couldn't photograph them because of the patient cooperation and eye conditions
Yeah.
and all that.
So how many out of the 100 that sat down at the machine did you get an image that you could read?
About 77%. Yeah. So this 12% is of those actually photographed. So about 88%.
No, what he's saying is that of the 100, 25 couldn't be imaged.
Yeah.
So it'll be around 65, 68%.
Yeah. If you look at the
Yeah,
total enrolled, that's true.
Yeah.
Yeah, you're right.
Yes.
Yes, Praveen.
In fact, I have a question from Sanil itself. You know, in India, we also do this DR screening something. We got a response rate of around 40%, but like people who are referred and going to hospital. Even in Australia, in your case, it is 48%, if I'm not wrong. Could you assess the reason why people, like they are educated, they are aware, and most of them are satisfied? Your satisfaction level is more than 75%. Still, they are not coming to hospital for further confirmation and diagnosis and treatment. Any reason for that?
Yeah, so we could get some information from those we could reach. I would include that data, but that comes in the publication. So main reason was because of the timing. Because some people would already have had an eye examination before we captured them. That was one reason. And then others had health issues. I mean, it was some of those issues like that. Those are the major 2 issues we could capture. But we did ask that question to people whom we could reach. Yeah. So I think that's a conception I also had. Like when it is a developed country, everything is much better, but it's very similar. I mean, that's the context for this study itself. We also did as a background, setting the background. We also did population-based secondary data evaluation of the Medicare statistics, and it was even the overall screening that is happening through the Medicare system was only about 1.5% of the prevalence of the diabetic population. So it's not great.
I think this is probably we have to really focus on it of one big research question. When people feel that they are fine, how do you make them go for because we have the same issue with glaucoma follow-up, DR follow-up, because the patient feel there's nothing wrong with them. No, so I think it's a $1 million research question. Yes, Priya, you had your hand up.
Just for you again. I'm curious, there was a very high proportion of acceptability, but there's obviously about 25% who were not accepting, the use of this sort of service. Did you try and understand those patients? Was it, what stage of disease were there? Was it an age thing? Was it a technology misconception? So was there any research done on that?
Yeah, so I had mentioned that about 13% were like neutral, so they were not dissatisfied. So the rest, I think the major thing that came up was the apprehension to technology. I mean, older people were less likely to accept. And because the whole thing was new to most of the people, and many people would be very anxious about missing the appointment. So initially we had that issue, then we started working, because it was a pragmatic trial, we could make modifications. So we started working with the GPs to give them more confidence, and even if they are late by a couple of minutes, they would get priority. So those are some of the issues in the initial stages.
Is it on the same,
Yeah.
huh?
Yeah, same.
So I would like to change the topic.
That's last one.
Okay, okay,
Because,
okay.
you said 15% of the provider also was not happy, though you really put it in during the waiting time. It actually helping them to spend out their waiting time effectively, but still 15% were not kind of positive about this implementation. I'm talking about the endocrinologist and all. What was their reason? It was not just the physicians, it was entire, we also had the clinic managers who were involved. And so sometimes in the initial stages, we had issues with the technology itself. So as we are setting up, so that would have given them some dissatisfaction.
Okay, I want to change the topic and ask ask Jnana a question and maybe a suggestion. When you do patient feedback, I think there is one school of thought, probably founded with evidence, that when you ask a patient when they are getting the service, they are kind of more reluctant to give a negative or a honest feedback. So quite often these feedbacks are done after they are discharged and they go home. Was this validated, or you are probably thinking about it, or because you are thinking you are doing the survey when the patient is in the hospital? No, that's how you described it. You want to explain that? You can use this, yeah, or you can take that, yeah.
Yes, sir. We have been changing this, the whole approach on a regular basis. So now we are also working on getting the feedback while even during the course of the treatment. And also we are going to send a link to the patient post the treatment. So the patient can give that feedback at their own time. That which also will comes back to the same system, which will evaluate and then it will add it into the system.
Maybe
So
we do a validation of both.
Yes,
I
sir.
think it'd be good learning if you can publish that.
Yes.
Yes, yes, Divya.
And a question. So one is you had mentioned that patients sometimes were hesitant to give open comments, but they would rather have wanted the comfort of a questionnaire. So what we found is once you have them go through a few questions, then they've started thinking about their experience, and then then the questionnaire becomes too constraining because they want to tell their story. Then you may have better storytelling from the patient side. So that's just one suggestion. My question is more about, you said you raise a lot of tickets based on the negative comments you receive. How do you track closure, and what does closed mean?
Yeah. So actually the tickets is not raised by us. It is it automatically
yes,
creates it, and
Yeah.
then it's a raised ticket in the particular the operational department area. So it comes to the dashboard. So which has been accessed by the patient care managers or the head of the institution, what we call the unit heads. They also access it. So then within that timeline we had set, so they study the transcription. They also listen if they have any doubt about the transcription given by the AA, and they do the root cause analysis, and they feed that information back in the same system, and they submit, and they're choosing that it's a particular item is closed. So that gives us a validation. So at the central level, we also track how many open tickets are there, how many tickets are in work in progress, how many are closed.
Typically, what percentage gets closed, say within even a month or so?
So, say for example, the most, if you look at the data of 1,678 tickets we are raised, about 55% of the tickets are related to the waiting time. So the questions related to the concern raised by the patients on the waiting time, that is where we see a lot time. Even sometimes the decisions we need to take, which also needs some resource requirement and the process change, it takes about a month or two. But rest of the other 45% of the questions we receive it, that gets solved within that week's time. Because we also have other system called the monthly review meetings, and also the weekly meeting called the one-point agenda meeting. So in that, these issues were discussed, and we close it.
Thank you. Thank you. Very useful.
Thank you. Yes.
It's an excellent initiative, including the name, the Sahai and all. So if you look at what was happening after the feedback was captured, it is something really excellent. But in terms of capturing, as you rightly mentioned, even patient was hesitant, because I think healthcare is one such where the customer is not so comfortable in giving feedback because they don't know what is going to happen next. I mean, they really feel scared, or what will happen to me, whether should I give the opinion or not. So if you look at the way you have shown the
the dissatisfaction is very minimal, which might be because of the way we are capturing, because it's like voice is captured, which people might not be so comfortable, like, because it's always going to be there. Otherwise, in the letters and all, probably you may say it was not filled by me, my son was filling, all this will there. So my question is, the way you approach is really good, because even current satisfaction survey feedback, we have not really used the AI in terms of analyzing it, closing it and all. So there itself fine. But do you thinking any other modality in terms of capturing it? At the next level, because right now I think it is really crucial, because we are really capturing the voice. So do you thought of any other modality in terms of capturing the feedback?
No, earlier we were using the like the traditional app-based patient feedback system. So similarly, we were giving to the patient. We have a kiosk where the patient themselves can key in, like we see it in the airports or anywhere. So we were using that also, and we were also sending the questionnaire-based, online questionnaire-based satisfaction also. But we feel that in this model, where the number of feedback we receive is more, and the authenticity also it's more, because the patient expresses what they wanted to talk about, their experience in the hospital, rather than that specific 4 or 5 questions we offer to them to answer for it. So though here also our patient care team will give them the cue about, sir, you are, because many times the patient will ask, what should I take? It was good only. No, I'm coming here for 10 years. You are good only. No, they say, sir, then we say, can you talk about, there are 2 things which you don't like or you want us to improve, like that. So that our teams also give that cues to the patient to make them share more information about the experience they had in the hospital.
Okay. The last question, comment. Yeah.
Just wanted to ask Dr. Sucheta, see, what sensitivity do you think you would be happy with in your tool? Because the baby might not be screened again. So what are the medical legals of implication, and when do you think it will actually be rolled out? Because Dr. Vinegar is also, I think, working on care.
Yes, there are 2-3 groups working on this. Ideal scenario would be 100% sensitivity. And for that, we need to have several thousands of images to go through that model. And with the speed of work that we are doing, we will need 3 or 4 more years to be able to do that. And despite being able to do that in 100% babies, I think the need for monitoring will be there always. Randomly choosing the images and going through it would always be there, and especially monitoring the images which have been identified as referable this thing. So I think so it's a long way to go. And again, the biggest challenge is getting the enough number of images. Yeah.
Thank you. This was really an excellent hour and a half, with, I think, very varied applications of technology, the impact, and as much as results were presented, it raised equal number of questions in our minds. I think that's what this session is intended to do. I was really kind of blown away by this idea that you do visual acuity and that can generate a prescription, right? That's more or less the idea that you had. No? Yeah. So these are all very phenomenal ideas and thoughts, and use of AI for patient feedback. I think very innovative ways of doing things. So thank you all to the speakers and equally to all the audience for the insightful questions. Thank you all.